Good morning, everyone. It gives me great pleasure to introduce Dr. Jocelyn Meza. Dr. Meza is an assistant professor in residence in the Department of Psychiatry and Biobehavioral Sciences and is a bilingual licensed clinical psychologist. Before joining the faculty, she has had extensive, rigorous training across several UC campuses. She first completed her BA in psychology with a minor in applied developmental psychology and graduated with honors from UCLA. She then went on to complete her PhD in clinical science at the University of California at Berkeley, where she completed her dissertation examining the longitudinal associations between childhood ADHD and suicide. While a graduate student, she also developed and coordinated a campus-wide mentoring program for historically underrepresented minoritized students with the ultimate goal of helping these students learn about and successfully apply and get into graduate programs across the country. This program, called GIGS, Getting into Graduate School, continues to help Berkeley underrepresented students and serves as a role model for other universities in supporting underrepresented students interested in graduate school. After completing her PhD at UC Berkeley, she continued her training and commitment to providing equitable care in a 2-year clinical internship at UCSF. While there, she worked on culturally adapted treatments for Latinx kids with ADHD, co-facilitated DBT groups for adolescents at high risk for self-harm and suicide, and also provided CBT for depression in Spanish. Her commitment to transforming the way we think about suicide has continued when she returned to UCLA to complete her first postdoctoral fellowship. Under the mentorship of Drs. Jeannie Miranda and Jonah Sarno, Dr. Meza was awarded the competitive and prestigious UC Chancellor's Postdoctoral Fellowship at UCSF, where she examined cultural factors associated with self-harm among court-involved adolescents, and also culturally adapted a brief family telehealth intervention for families and adolescents placed out of home. After successfully completing her second postdoctoral fellowship at UCSF, she returned to UCLA to join our faculty. Currently, she is the Associate Director of the Youth Stress and Mood Program and the Principal Investigator of the Health, Equity, and Access Research and Treatment, HEART, lab at UCLA. Her research interests include studying socio-ecological risk and protective factors for suicide and self-harming behaviors among Black and Latinx youth. She aims to integrate psychological, cognitive, and socio-cultural influences to predict suicide and self-harm behaviors, and importantly, to identify therapeutic targets for culturally responsive interventions for ethno-racially minoritized youth. In addition, Dr. Meza is expanding her research to adapt evidence-based psychosocial interventions for ethno-racially diverse youth, particularly Black and Latinx youth and systems-involved youth, those who are involved in both the juvenile legal system and child welfare system. The late poet and Black literary feminist scholar, Dr. June Jordan, wrote, "We are the ones that we've been waiting for." And this is so true about Jocelyn, who's committed her blossoming career at the interface of social justice and health with the fierce urgency of now. On the personal note, she's an incredible friend, peer mentor, visionary research scholar who is doing disruptive science to advance equitable behavioral health outcomes for ethno-racially minoritized youth across various systems and oppressive structures. This is critical work that advances behavioral health equity for all and thus has notable public health significance and impact. She approaches this work with critical perceptivity that's anchored in anti-racism and culturally responsive frameworks. She is a thought partner and is an important voice in shaping child mental health. So without further ado, I give you Dr. Meza.
Thank you so much, Dr. Bath. That was probably the nicest introduction anybody could have done for me, so I appreciate you. Now I really have to deliver after that introduction. All righty, let me get started and share my screen. All right, unless I hear otherwise, I think everyone can see my slides, and I think I can move forward. Please stop me if for some reason you can't see my slides. I can't really monitor the chat at the moment, but feel free to stop me. Good morning, everyone. I'm so excited to be here. I'm sad I can't see any faces because I really thrive of like social interaction. So hopefully I will get to meet you off camera and get to have a dialogue about this really important topic. And hopefully this presentation today on risk and protective factors associated with suicide and self-harm among ethnoracially minoritized youth will serve as a springboard for me to have a lot of dialogue and hopefully collaborations with you all on this important topic. Okay, our mandatory financial disclosures. These are my current funding mechanisms. I also do not have any conflicts of interest to report at this time. And to give you a little idea of what to expect in this talk, I'm first going to start talking about a little bit of the scope of the problem. And I'm going to spend some time discussing some current disparities. I will then review some current social, cultural risk and protective factors associated with suicide. And I will wrap up with a discussion on some possible equitable solutions that we can implement, both from a clinical and a research perspective on how can we improve our work in suicide prevention. Hopefully by the end of this talk, all of you will be able to understand the current prevalence rates of suicide and how they vary by race, ethnicity. I will also hope that you will be able to describe culturally relevant risk and protective factors associated with suicide. For this specific talk, I'm focusing on Latinx and Black youth, but I do have some slides on Asian American and Native American youth if you're interested in having some discussion around that. But given some time limitations, I'm particularly focusing on Latinx and Black youth today. And then by the end of this talk, I hope you will all be able to articulate not just the gaps that are impacting our suicide prevention, but we'll also be able to articulate what are some possible solutions that can address these gaps. Okay, so many of you might have seen this graph already. This is from the CDC. I'm using data from 2019. But as you can see here in this graph, suicide is the second leading cause of death for youth between the ages of 10 and 34. I primarily focus on adolescents that are either in high school or young adults that are college-age students. But you can see, and it's very alarming, that suicide is the second leading cause of death despite many evidence-based treatments that have been tested to date. So what is it about our current strategies and interventions that is not impacting this area? What can we do so that suicide doesn't continue to increase among our youth and young adults? The problem with this figure is that it doesn't really give you data at a glance. It really doesn't give us an idea of what is the prevalence of this problem. So I always really like to present, oh, I don't know why, there we go. I always really like to present data from the Youth Risk Behavior Survey because it really captures the different prevalence rates of these different self-injurious thoughts and behaviors. So as you can see here, nearly 1 in 5 high school students seriously consider suicide, which is a really, really high prevalence rate. 16% of high school students report a previous suicide attempt, and I will say this is in the last 12 months. So at time of the survey, they report any attempts in the last 12 months. These are not lifetime, which even makes this prevalence rate even more alarming. 9% have made a suicide attempt, and out of those youth that did have a suicide attempt, 2.5 reported a significant physical injury that required some sort of medical treatment. So as you can see here, rates are really high across the board for suicide, for self-injurious thoughts and behaviors, and we need to do something to disrupt this. What this doesn't tell you, however, are the differences across race and ethnicity. And we know that this is important because they are significant racial and ethnic disparities for suicide. particularly for Native American and Alaska Native youth. For these youth between the ages of 10 to 14, suicide is actually the #1 cause of death. And we also know that there are significant increasing rates among Black and Latinx youth. And currently the highest increase for suicide attempts has been noted for Black girls between the ages of 14 to 18. So adolescent girls. Here, what we did in a previous publication, Dr. Bath and I, is we looked at the data for the Youth Risk Behavior Survey, and we looked at these different behaviors across race ethnicity to be able to visualize how these rates vary by race ethnicity. I already talked about the first 3 on the left here, but if you can look down for female suicide attempts, you will see that there are some significant discrepancies and disparities. For non-Hispanic white girls, the prevalence rate is 9.4. When you compare it to non-Hispanic Black girls, you see that this prevalence rate increases significantly to 15.2%. And for Hispanic and Latinx girls, 11.9%. We see a similar trend, but lower rates for male suicide attempts. So what can we do to disrupt these current disparities? We know, I think I mentioned this briefly in my opening, but we know that in the last 20 years, rates of suicide have not gone down. The age-adjusted rate is 33%. But when we look at these increases by race ethnicity, we can see that the highest or sharpest increase across time in the last 20 years have been for Latinx and Black girls. So 133% increase in suicide attempts for Latinx girls and 125% increase for Black girls. And you can compare this to 61% increase among non-Hispanic white girls and 88% and 61% for Asian girls in the same age group. And notably, there's been a lot of discussion. There's been the Congressional Black Caucus issued the Ring the Alarm report, and where they noted that Black youth ages 5 to 12 have a suicide rate that is roughly 2 times higher than white children the same age group. So I don't think I need to continue talking about this, these disparities to really show that this is an alarming area that we really need to address and think about it in a different way, because the way that we have been addressing this issue has not moved the needle significantly. This beautiful graph is from one of Dr. Bath's publications, but as you can see here, rates of suicide for Black youth is not a new trend. This is something that has been documented since the 80s. And yet, despite this, we haven't really addressed this issue. We found very similar trends for other racial and ethnic groups. I'm sorry, my screen isn't moving. There we go. We've noticed similar trends for other groups. So we see that, for example, for Latinx youth, increases in rates of suicide have been noted since the late 1990s, and yet we haven't really addressed this problem in our clinical services. So my question, the question that I hope to address through my work, not just through my research, but through my clinical work, is how can we disrupt these current disparities, and really try to hone in and trying to understand what are the social cultural drivers, what are the things that are currently driving these inequities. One of the main issues on why we haven't really moved the needle on improving suicide for Black and Brown lives is that what we know about suicide is largely decontextualized. So what do I mean by that? About 80% or 90% of our work to date of what has impacted our suicide treatments has primarily focused on the individual and microsystem level. So we know a lot about what individual level factors, what family level factors, what peer-related factors are associated with suicide. However, we really haven't put enough attention on understanding the broader context. So how do things like discrimination, systemic racism, culture, how do those things impact suicide? And this is something that was brought up as a significant issue by Jonathan Singer, who was the previous president of the American Association of Suicidology. And he actually resigned shortly after this brief statement that I'm going to read that he made. So he noted, the work of suicide prevention is grounded in the assumption that people live in a world that believes their lives matter. Many people of color, however, do not see the world as their own. On a practical, daily level, society gives explicit and implicit messages that it's white lives that matter, not Black and brown lives or Indigenous lives that matter. So after he issued this statement, he received a lot of pushback in terms of his idea of wanting to focus on how social cultural context impacts suicide. He ended up resigning, but I think his statement is so true to the work that I'm doing. How can we make sure that our work is giving off the message that Black and brown lives matter? And in order to do so, what we need to do is take a ground zero approach. So what does that mean? That means going back into the drawing board, using our public health model of suicide prevention and understanding, for example, the problem of suicide through an intersectional framework, right? So just how I did earlier, trying to understand how different self-injurious thoughts and behaviors vary by race, ethnicity, and other social identifiers. After we understand the current problem through an intersectional framework, we need to understand and go back and try to understand and uncover what are some risk and protective factors in the broader context, right? Not just at the individual and family level, but in the broader context that can influence self-harm and suicide. Only then will we be able to use that work on culturally relevant risk and protective factors to inform our evidence-based treatment. And the whole premise of suicide prevention is based on that second step of the public health model. It's not just on reducing risk, which is associated with certain groups, but also enhancing protective processes, which is why my work is really focused on risk and protective factors for these, what we call high-risk groups. My work to date has focused on uncovering risk and protective factors among Black youth, among Latinx youth, and some of my more recent work and in collaborations with Dr. Beth is focusing on youth that are impacted by different social systems. So these are kids that are impacted by the juvenile legal system. These are kids that are impacted by child welfare, or these kids that are dually involved and impacted by both. I know we don't have a whole lot of time, so if time permits, we can talk about juvenile legal system and child welfare, but for today's talk, I'm primarily focusing on my work on Black and Latinx youth or children. So let me start by talking about some work that has elucidated risk and protective factors among Latinx youth. Before I go any further, I always like to start with a statement on how Latinx youth, I know it's a really big umbrella term, and it really captures a very heterogeneous group. So these are kids from different backgrounds, right? So Cuban, Mexican, Guatemalan, it's a very heterogeneous group, and we need to understand how various groups may be impacted differently, because there are different historical and immigration histories within each group across the country. So it will look very different in terms of mental health and acculturative stress for a Mexican descent adolescent that lives in Los Angeles, where the main group is Mexican American, versus a Puerto Rican youth growing up in New York. So context matters, immigration history matters, and also generational status. And I'm going to talk a little bit about how being born in your native country and immigrating may look differently in terms of risk for suicide for someone that may be second or third generation. There seems to be some protective processes for first generation Latinx adolescents. So what do we know in terms of individual culturally relevant risk factors associated with suicide for Latinx youth? In this graph, you can see here, this is a study conducted with a group of Latinx college students. And what they found was that low identity attachment. So identity attachment is your sense of belonging and commitment to your ethnic group. So what they found here is that if you have really low ethnic identity attachment, that was actually associated with higher risk of suicide through perceived thwarted belongingness, so feeling like you don't really fit into your group, and perceived burdensomeness, so feeling like you are a burden to society. So this is really important because we need to think about how are we going to integrate these types of risk factors into our interventions. I don't have a whole lot of time to go into these, but other things like generational status have been shown to be associated with suicide attempts, particularly with females. So with Latinas, they have found that being second and third generation, so being born in this country, but having a parent that was a recent immigrant, was associated with higher odds or higher risk of suicide attempt. Again, immigration histories have also been associated with more acculturative stress, and there also seems to be a pattern with girls reporting higher risk of suicide from perceived acculturative stress. If we look at the family context or at the family level, we have found in our own work that parental incarceration has been associated with higher odds of suicide ideation and attempts. And I want to put a pause here and say that it wasn't parent incarceration on its own that led to higher risk of suicide. In our work, in a sample of Black and Latinx girls that were commercially sexually exploited, we found that girls that had a parent that was incarcerated and had more disruptive behavior problems, that combination is what led to a higher risk of suicide. In addition to also having more out-of-home placements. So it was those three things working together that led to higher risk. So child welfare, out-of-home placements, parental incarceration, and some form of externalizing psychopathology. And why do I think this is important? If we think about our treatments for suicide, they have a heavy component on family and having the parents involved in the treatment. And we know that that's a important ingredient in making our interventions work. So how do we deliver these interventions for youth that have a parent that's incarcerated? How can we think about our suicide prevention for kids that have one or both parents that are impacted by the criminal system and that are incarcerated? In some of my recent work, this is from, there we go. This is from a study in where we collected data from Latinas that were enrolled in a four-year university across the country. So we received about 246 Latina college students. And we did a survey asking them about how much conflict they had with their parent as a result of having cultural differences. So to this, we refer to intergenerational acculturation conflict. This is the conflict that you have with your caregiver because of differences in your cultural values. And what we found in this cross-national study is that depression severity on its own was a predictor of suicide attempts. But when you also had really high intergenerational acculturation conflict with your parent, and in particular with your male caregiver, that is what led to the highest probability or highest risk of suicide. So there seems to be an interesting interaction here with having more conflict with male caregiver in Latinx college students. So the girls that had both high symptoms of depression and high intergenerational acculturation conflict, those were the girls that had the highest risk overall for suicide attempt. And in a second study, and where we focused on their conflict with their mother, and we really wanted to focus on conflict with mother in this particular study, was because a lot of literature has suggested that mothers are usually the transmitters of culture, right? The moms are the ones that really relay and do a lot of the socialization into the cultural values. And it's important to understand what aspects of this intergenerational acculturation conflict leads to suicide. Because when we think about acculturation, we need to understand that it's a bi-directional process. It's both adapting new values, so that's what we call acculturation, and maintaining your own Mexican heritage values or your cultural values. That's what we call enculturation. And what we found here is that discrepancies in acculturative values that actually wasn't associated with suicide risk or suicide ideation. It was the enculturative values discrepancy between mom and youth that led to suicide ideation. So something about differences in your Mexican heritage cultural values and differences with your parent is what led to this higher risk. Okay, and what about at the broadest level, at the social and community level? We know from some recent work that everyday, well, I shouldn't say everyday, but discrimination or experiences of microaggressions have been associated with both ideation in both Latinx and Black youth. And one new area and what we're focusing on in our lab is that during the COVID pandemic, we saw increases in perceived racial bias. And in one study that we're currently working on in the lab, we found that for Latinx college students, their perceived racial bias during the COVID pandemic not only led to more perceived stress, but it also led to more symptoms of depression and ultimately more attempts during the pandemic. So here, what you can see on the screen is the indirect pathways of perceived racial bias and how that was associated with suicide attempts during the COVID pandemic for Latinx youth. I also don't want to portray culture as in a deficit framework, so showing that there's so many risk factors associated with one cultures. We need to understand culture through a cultural assets framework, meaning that there's a lot of resilience and strength in one's culture. And in particular for Latinx groups, we see that having a stronger sense of belonging and identification with your ethnic group, that can be really protective, especially for Latinx youth. I know we're a little bit tight on time, so I'm gonna skip this slide because I wanted to focus on this last slide. There has been some really interesting work within college students to find or to look at how political activism or political engagement on campus can be a protective factor that can mitigate the negative effect of racial and ethnic discrimination on stress and depression symptoms among Latinx students. And in this very neat lab study, they found that if students receive a message of cultural diversity and inclusion, that this somehow reduce their stress responses. So thinking about suicide prevention with college students, if we do implement more messages and daily reminders to college students on cultural diversity and inclusion, this could have some really good potential benefits for their mental health, in particular for their suicide ideation. Okay, so now pivoting a little bit to contextualizing Black youth suicide. I mentioned earlier that there's been some studies that show that there's an indirect effect of discrimination on suicide ideation and attempts. We know that subtle forms of discrimination not only affect your self-esteem, but they also provoke more feelings of threat and vigilance. They increase psychological stress responses, and they also lead to more feelings of isolation and rejection. One thing that we're doing in the lab right now, if you're interested, is we're trying to understand what are the mechanisms that explain that relationship between discrimination and suicide behaviors among college students. Is it through perceived belongingness or thwarted belongingness and perceived burdensomeness? And can other culturally relevant factors like ethnic identity and racial pride serve as protective factors in this link? There's been a lot of studies focusing on discrimination on college campuses, and we know that these rates are pretty high, particularly for Black youth. So how can we address this problem that we know it's leading to their suicide ideation and attempts of suicide? How can we make sure that we're integrating ways of coping and resisting with racism and discrimination to these students? I'm going to talk about in a little bit about a current evidence-based treatment that does just exactly that in order to prevent suicide. Some other risk factors associated with suicide for Black youth. We know that increasing involvement in both the child welfare and juvenile legal system are very risky for suicide. Current rates report that youth that are impacted by these systems are 3 to 4 times at higher risk for suicide. This is from a previous study that Dr. Bath and I did, and we looked at a systematic review of risk and protective factors for both Black and Latinx youth. I know I talked about Latinx youth a little bit already, but you can see on the left side that there's actually a lot of protective factors that we can integrate into our interventions for Black youth. So some of these things are having a strong Black identity, or what we refer to as racial pride, cultural cohesion, spirituality. How can we integrate these factors that I'm showing you here into our current treatments? And I think this is particularly important because although there are so many barriers to getting treatment in general for Black and Latinx youth, for suicide, there's even more barriers. And this is because there isn't a lot of availability of treatments that work for suicide for Black and Latinx youth. So what I mean by this is that dialectical behavior therapy, we know it's a well-established treatment, is the only treatment to date that has been classified as a level 1, meaning that it has 2 independent RCTs that has shown its effectiveness. Yet we don't have a lot of DBT clinicians of color. How can we make sure that the treatment that works is easily accessible to these youth, which it currently isn't. A lot of our work as well in terms of suicide prevention has focused on developing interventions that are delivered in our health system. So inpatient, focusing on our emergency department, focusing on primary care, which I think has done a lot of really good work in terms of improving detection of suicide. However, what happens to the youth that don't make it into these systems of care? How can we meet them where they're at to deliver these interventions? Some work right now has focused on using the Black church as a space of delivering suicide interventions. Some of my recent work right now is focusing on public libraries and parks as a safe space where families can feel trust to receive mental health services. So my point here is that we need to meet our youth that are at risk, our Black and Latinx youth. We need to meet them where they're at. We need to go into the community to deliver and deploy some of these services. Okay, so as promised, I said I would spend some time to think about and to discuss what is our current state of evidence-based treatment for suicide, and how have we or failed to focus on culturally relevant factors in our treatment. I love this current chapter by Dr. Jovanska Duarte Velez. She's over at Brown and a great colleague. And what she did in this chapter is, she reviewed all of the evidence-based treatment to date for youth. And what she did is she classified them based on how much they integrated culturally relevant context, and how much they included different ethno-racial groups. So those that are classified as A, those were treatments that were specifically designed for a particular ethnocultural group. Those that are classified in B, so on the bottom, are those treatments that were not for a particular group, but they did give some attention to the cultural context. And then those classified as C were those treatments that didn't discuss the ethnocultural context, but had some Latinx youth in their trials. As you can see here, there's only 2 treatments actually to date that have been specifically designed for a specific ethnocultural group, and only 2 that have considered the cultural context into the treatment. As you can see here, so there's 2 very good trials that I want to highlight in this conversation. One trial is the one that I just mentioned, is a social cognitive behavioral therapy for Latinx adolescents. It was recently published, I would say maybe 2-3 weeks ago, and it focuses on improving suicide outcomes for Latinx youth. And then the one below was published last year, and it's an intervention designed for Black youth suicide, and it specifically focuses on how to cope and resist with racism. So these are the I would say the only 2 interventions to date that have done a randomized controlled trial and have really embedded the cultural context into their treatment. So I want to spend some time talking about why I think they have really worked for these groups. So the first one is the social cognitive behavioral therapy for suicidal behaviors. What I really like about this intervention is that they integrated a whole module that focuses on parenting a teen that has different cultural values than you. So they have a whole module that focuses on addressing the intergeneration acculturation conflict, which, if you remember from a few slides ago, is a culturally relevant factor that's associated with suicide. So they've integrated that into their treatment, and in their RCT, they found significant effects for both ideation and attempts. So this it's very innovative, and I think it has a lot of potential for addressing our disparities. The second one that I mentioned was the adapted coping with stress intervention. It's different from the one I just mentioned because it has a group approach. So teens receive this intervention in a group format, and it did include a community-based participatory research. So what they did is they involved a lot of Black parents, a lot of youth that had lived experiences with suicide, and they asked them about what are some of the things that impacted your mental health and how can we integrate it into our intervention. And a lot of the feedback that they got from the community is that they were feeling that they didn't have the skills to deal with a lot of race-related stress. So things like with racism, and this is an example of one of the figures that they use in their handouts. So this whole intervention focused on helping youth and parents develop skills on how to cope and resist with racism. And it received very good acceptability ratings from families and from teens. Okay, I'll move forward. This is another example of how the intervention included feedback from the community on how to address racism across context. So again, both this intervention and the intervention by Jovanska Duarte Velez, I think there are two excellent examples of how you can integrate the social cultural context into our treatment. So I want to, in the last 5 minutes that we have here, is to wrap up in thinking about what can we do as clinical scientists to improve our current state of suicide prevention and make it more equitable. So this is from a publication that Dr. Bath and I published last year, 2 years ago, and we discussed some strategies that we think, based on our collective expertise and experiences, that we think can really help improve suicide prevention from an equity lens. So our 6 recommendations were, the first one is, as researchers, we need to identify and integrate the identification of cultural risk and protective factors into our work. So how can things like acculturative stress, discrimination, ethnic identity, racial pride, how do these things serve as risk or protective factors for suicide? What are the mechanisms that link, for example, discrimination and self-harm? A few of our studies right now that are going on right now are doing exactly that, trying to understand the culturally relevant mechanisms and some culturally nuanced protective factors. Number 2 is to expand our screening to consider racism, discrimination, and racial trauma. So if you're a clinician, I want you to reflect on, when you see your patients, if you see patients of color, do you ask about experiences of discrimination? Is this something that you actively screen when working with these youth? If yes, wonderful. If no, what's stopping you? What are some things that are getting in the way? Number 3, invest in cultural adaptations of existing evidence-based protocols. So I mentioned there's 2 really great ones. And this is an area that hasn't received a lot of funding, although now there has been a shift in getting more funding. Culturally adapted treatments, I think, now are receiving more funding support. Number 4, identify structural barriers to delivery of care. So for example, not a lot of families that have high suicide risk have the 3 hours to enroll in a full DBT program. How can we think about our treatments and make them more accessible? Will telehealth be a possibility? Will delivering these interventions in trusted community settings be a possibility to increase access? Number 5 is to ensure the inclusivity of diverse samples and to the analyses of these interventions. And this will take, this can only happen if you include and integrate the investigative team to represent the cultural group or the community that you are interested in getting into your treatments. And then the last one here is focusing on workforce training in cultural competency and anti-racist clinical care. This is something that I didn't receive when I was a clinical psychology graduate student, and I think it's more important now more than ever to really make sure that there are required mandatory trainings for cultural competency and anti-racist clinical care, and thinking about how we can build cultural humility and cultural safety into our clinical practice. Okay, I am right on time. I was told to stop at right at 11:45 to have some room for discussion. So Dr. Bath, I noticed that there's like 2 Q&As, but I don't know.
Sure, yeah, there's a question from Dr. Luxembourg. In deciding how much a college student was close to their culture was religion questioned, for example, Catholic versus indigenous religion, and what was the amount of drug or alcohol use with regards to the suicide rate, attempt rate.
Okay, I'm assuming this was for the study that there were several studies that I focused on college students. So for this, the study that I mentioned earlier, the first one, we did ask about their religiosity. I would say there wasn't a lot of variance for that. We saw that most of the Latinx college students reported being Catholic, and having Catholicism being their main like religious background. What we didn't ask though was how they behaved in ways that were concordant with their religious background. So things like going to church, right, or praying. Was this something that was associated with self-harm? So it's not just identifying as having a certain religious background, it's also how you behave accordingly to that has been shown to be protective in suicide. And then your second part of your question was, did we look at alcohol use and substance use in this sample? We did, but it wasn't part of this study, but we found very high rates. I think about 40% had pretty high rates of not drug use, but alcohol use in particular.
Okay, our next question is from Dr. Evans, who was wondering about the reaction of different cultures and cultural dominant religions to gender identity play into suicide disparities.
Okay, so I wonder if this is a question. See, this is why I wish we were in dialogue together. I wonder if this is getting at the intersectionality of both culture and gender identity, and how that may play a role into suicide. I mean, we didn't study that in our study, but I can see how different religion or religious identity does interact with gender identity to predict suicide.
Yeah, I don't know, Dr. Evans, if you were speaking also to thinking about youth, sexual minority youth. And perhaps because they do have increased risk, and I know on the chart, one of the charts or slides that Dr. Meza had, she identified them as a population. And then if we just think about intersectional risk, how
right,
it overlaps.
And I mean, this is not, an area of expertise for me, but a lot of folk out there, for example, Jovanska Duarte Velez, she does focus on sexual gender minority Latinx youth. And that intervention that I talked about does focus on communication with the youth on things like that. And sometimes certain religious backgrounds are not supportive of some of those identities, right? So how do you consolidate those two things?
Okay, we also have a question by Dr. Ito. Is there any data about whether means of suicide attempts, for example, overdose, hanging firearms, are varied by race?
Yeah, so we have looked at, we've tried to address that question. Most deaths by suicide for youth 14 and up are primarily by firearm. And then the number 2 is suffocation. There is some data, however, to show that Black boys, or Black adolescent boys in particular, are more likely to die or have an attempt by firearm, and that they have more lethal medical consequences, meaning that they're using more lethal means. So for example, firearms, right? And this is something that we need to integrate when we're doing a lot of the means restriction counseling, because a lot of these youth say that they feel that they need to have a firearm in order to feel safe in the communities that they live, right? So this is where we need to be very strategic and helpful and thinking about how do we do means restriction counseling with these youth that do live in risky or more violence-prone neighborhoods.
Well, and I think to that point also, there's been advocacy around gun legislation and control because it really actually impacts ethno-racially minoritized communities disproportionately. And so people forget about the public health implications of our lack of a lot of gun safety legislation.
Exactly. And this is also, I also want to add another layer to that, Dr. Bath, is thinking about Black youth that are impacted by the juvenile legal system, right? And thinking about the reentry period. Can we use that period as a clinical intervention period to do lethal means counseling with the parents, right? With these youth that a lot of them have been incarcerated because of gun possession or having these things.
Dr. Vargas is asking, how do you see immigration stress as a risk factor for youth and how to consider as an area for intervention?
Yes. Oh, that's such an excellent question. So how do we see immigration stress as a risk factor? So if we think about different things happening during this period. So first we need to think about what was the reason for immigration or for moving. And for some people, it will be for, political warfare in your country. For others, for my parents, for example, they immigrated into this country because they wanted a better opportunity for themselves. So we need to think about what is the reason that's leading to the move from their country, because there's a lot of trauma that happens during the actual move, during immigration. There's a lot of sexual violence for women that do make that move. And also, if you think about a youth, right, are they accompanied? Are they coming with their family? What type of support are they getting when they're moving into this country? There's also a lot of stress related with language, right? So for a lot of these youth that don't speak English, they're being put into an environment and where they don't speak that language. So what types of support are they getting? Is their family around them? There's a lot of really interesting literature on unaccompanied youth, right, that come into this country that they do experience, I would say, more unique stress related to their immigration. And how can we consider this into our intervention? I really think that there needs to be a specific intervention that focuses on addressing the trauma related with immigration into this treatment. So addressing trauma, I would say, is an important way of integrating this into the intervention.
Another question from Dr. Osuna was asking about how acculturation stress may differ between first or second generation youth, both Black youth and Latinx youth.
Okay, so I can speak for Latinx youth and what we've done in our own studies. So you're exactly right. Being first generation youth has been implicated to be a protective factor. And if you think about it, what is it about first generation, right, versus second and third that is protective? So these are the youth that are born in their country and then move at a later age into the US. So there may be less enculturative conflict, right? So there may be less discrepancies between your cultural values from your home country. And if you remember from a previous slides, that's what was leading to higher risk of suicide, was that not the acculturation, the enculturation differences. And there's significantly fewer enculturative differences when there's their first generation, because they're holding on to a lot of their home values still.
Okay, Dr. Thames, how does gang membership play a role in these risk factors? Is it protective because there's a sense of family, or risk due to firearms, incarceration? What is consensus around this, if any?
Oh, I love this question because we were actually, we had a sample of 50 re-entry Black and Latinx boys. And a lot of them talked about gang affiliation in a positive way, in that they felt that they had a community that supported them. So there was also, like you said, that sense of community support. But on the other hand, a lot of the activities that they engage with other gang members was what led to their incarceration and to their recidivism, ultimately. So I would say that gang affiliation and membership is like that double-edged sword, right? It can serve as a sense of community, but it could also put you in situations that might get you in trouble, right? And it didn't have, so we tested whether gang affiliation was associated with self-harm risk or suicide, and it wasn't. It was not. It was mostly the parental incarceration that was associated with higher risk of suicide.
From Dr. Callejas, wonderful presentation. Can you comment more explicitly on the role of family intervention and more systems level interventions relative to more individualistic intervention models?
Yes. So thank you for that question. What do I mean by individual level interventions? So these interventions are the interventions that target symptom reduction, right? So how do you improve depression? How do you improve emotion dysregulation? Versus the community level interventions are the interventions that target things like having resources for getting housing and food stability. These are things that focus on structural things and how to actually address them. Things like how to resist and cope with racism, how do you consolidate or talk about acculturative conflict with your parents. So these type of interventions focus on the broader context in addressing suicide. I hope that answered. Your question was removed, so I don't know if I answered it. Wow.
Sorry, I'm trying. I think, yes, sort of, I think thinking about things across the ecological framework, so moving from individual to family.
Exactly.
Dr. Ito had a comment from the prior question where we were talking about sexually minoritized youth. And so for racial minority LGBTQ youth, higher juvenile legal system involvement, less out to family, lower social supports within racial community, more online supports, rejection and racism due to race within LGBTQ community, LGBTQ prejudice within racial community, also just experiencing discrimination for being LGBTQ, less healthcare access equals less avenues belonging, less protective factors, and thus increased suicide risk. So this is like ecological, structural, intersectional snaps.
Right. It reminded me of our conversation, Dr. Bath, of like a lot of the work on suicide has focused on like siloing some of this data. So there's definitely a lot of work on SGM youth and suicide. There's some work on Latinx youth and suicide, but there isn't a lot of work that integrates both of these identities. And we also need to understand that youth with marginalized identities are also embedded within systems that are racist, right? So a lot of these SGM, Black and Latinx youth, well, guess what? They're also disproportionately impacted by the juvenile legal system. They're more likely to have out-of-home placements in child welfare. So how can we integrate all of these things that we're talking about into into our work that we're doing? We need to stop siloing the data and really, like you said, Dr. Bath, take a structural intersectionality approach.
Do you have any closing comments? We are at 11:59.
I know, I mean, I could really go on a rant for a really long time talking about something. I'm very, very passionate about improving the lives of Black and Brown kids, especially those kids that have been marginalized and really not integrated into our research. So if this is something that you also really care about, please reach out to us. We are eager to have dialogue around this and to integrate multiple ways of thinking about this, but we want to be disruptive. We want to think about this from a different perspective because it's what we need. We need the ground zero approach to address this problem. Right at 12, we finished right on time.
Yeah,
Thanks,
thank
Dr.
you for
Bath.
an amazing presentation. It was really illuminating, and it shows that we have so much opportunity to start thinking different, and expanding the narrative in terms of how we really innovate and approach suicide prevention and treatment.
Exactly.
So thank you.
Thank you. And we look forward to hearing from you all, hopefully for some dialogue.